or two. Again, I want to thank you all for attending. And at the end, as Kat had mentioned in the beginning, we're going to have, when you close out, it'll have a survey question that comes up, and it will ask, what would you like to see for next year? So please take time and let us know that. We would love to take that information and do a better job. We want to do a better job for you every year and give you meet your needs and give you what helps. So let's see here. Okay, the first subject that we're going to talk about this afternoon is something that many of us have had to deal with or have had some involvement with, whether it be hands-on or possibly by phone if someone was calling for advice on what to do. Many of our coworkers have dealt with this. The information that I'm going to share has to do with emergency response, such as calling 911 and or staff recognizing the need for further medical follow-up. These are ideas that you can think about and take back to your agencies to see if it can help with this stress-inducing type of event. It is very stressful, and there is some information I want to share with you that will hopefully help it be less stressful. I'm going to share my screen. And I titled this Emergency Response, because that is what it is. When you recognize an emergency and what's the response to it. I'm gonna switch my move some out of the way. Oops, that's not, there we go. Okay, good deal. My slides weren't advancing. All right, mortality data. Here in Missouri, when an individual receiving residential services passes away, we are required to complete a mortality review related to their death. The purpose of the review is to determine if there was anything that could have been done differently in order to have prevented the individual's death, or if there is something that we can learn from it to prevent or identify earlier any adverse outcomes. One thing that we do look at is whether or not emergency response was implemented or whether there was a delay in calling 911. Another thing that we look at, medical emergency consumer in the event reports. That's something that can be indicated on the event reports. The events are reviewed at varying levels. And one thing that we look at is what is needed to assist you all with supporting the individuals out there. A common theme that we do see is a delay in calling 911 when an emergency is occurring. So what we feel like that's our cue to help you all prepare people or get information out there in order for them to, just do the best they can and get that emergency help as soon as they can and recognize when they need to. So I'm hoping that what we talk about right now will give you guys ideas and help. We do have an aging population. We need to be prepared for additional situations where an emergency response is necessary because people are living longer, which is wonderful. We're keeping them healthier. Risk mitigation. Part of the services we provide are to minimize risks for the people we serve and provide a culture of safety. Staff are to be trained in CPR and first aid, and it is difficult for them to determine whether a situation warrants calling 911 sometimes. Oftentimes a person might panic and maybe call a supervisor first or the agency oversight RN because it's just, you don't deal with it every day. So it's really hard to know how to act. And here is a poll question that I'm just throwing out there, kind of curious as to how this, what all you've encountered. But have you ever been called in an emergency situation when 911 should have been called first? And you can answer yes or no. And of course, we'll look at the results as a group after they are tallied. So please just don't hesitate to answer. Ever been called in an emergency situation when 911 should have been called first? It looks like time's almost up. Okay, awaiting the results. Okay, about equal yes, equal no. Okay, all right. Interesting. It just varies. Okay, how to be prepared. How do you prepare for an emergency when you don't, you just don't know when an emergency might strike? Well, the agency should have a policy related to staff's expectations in an emergency. Agency oversight RN role in emergency response. Learn your agency's policy for what is expected when an emergency situation occurs. Sometimes agency staff, as we just said, have a difficult time ascertaining that an emergency is occurring. On the Division of DD's website, you can find a help guide that staff can read and review as a reminder on how to determine an emergency. It is called Just Not Right. And I'm going to put the link in the chat. If you just give me a second to do that. All right. Okay, I'll post it in the chat when I'm done. I have too many screens open, I think. But I will definitely share that because it's a pretty good tool to kind of help, get your mind wrapped around, identifying when someone's just not acting right and if they need 911 attention or what the next steps can be. Experiential practice testing, which is just practicing. It has been proven to be effective as related in Science Codex in May 2009, which refers to a Johns Hopkins Children's Center study. There was a significant improvement in emergency response with nurses when staging mock cardiopulmonary arrest with life-size dummies. And then I have the study link right here that I can post. It is just proven that with practice, or even if the staff were to review in their mind, okay, here I am in the home. Okay, what would I do if something happened? And it's okay, nurses and directors and whomever, to ask you, pose that to your staff. What would you do if something happened? And then they can kind of get their mind wrapped around it and kind of talk themselves through the steps of, what I call 911, stay on the phone, just how they would respond. Because really that's one thing that can help keep a person from becoming just kind of paralyzed with fear and just, oh, what's my next step, and calling the supervisor before calling 911. Okay, so tips for staff. According to 911.gov, many 911 call centers follow protocols that guide callers through a sequence of questions to quickly obtain information necessary for dispatching the right responders to the right location. Call takers may also provide instructions about what to do until help arrives. Even though protocols are designed to help call takers reassure the callers and take charge of the situation, the experience can be stressful for a 911 caller who is not accustomed to dealing with emergencies. When you call 911, be prepared to answer the call taker's questions, which may include the location of the emergency, including the street address. So if you commonly work in a home, or your staff, they work in the same home, or even perhaps not, have that address somewhere posted somewhere, so that if they did need to call 911, they can tell the operator exactly where they are. 911.gov also recommends that if you're in a large building, be explicit as to where you're located in that building. They often ask what phone number you are calling from. So if the home has its own landline or personal phone, have that posted. Make sure that they can, so that they can identify that if asked. Details about the emergency, such as a description of injuries or symptoms being experienced by a person having a medical emergency. If they're able to tell them just tell them what's going on when they're called. Accurately relay situation, just the facts. Do not diagnose. Can the person give the facts of what is happening and pertinent background medical information? So, sometimes people will have little medical sheets that has just some health history or what have you, and medications that can be available. So that way, whenever emergency response arrives, they can see what their health concerns have been and help determine how to help that person. Let's see, does the employee know how the person has been acting lately, whether vomiting, running a temperature? Does the employee know if a person has a do not resuscitate order? That's important as well. So that's all things that you all can help to clarify to make situations maybe have an optimal outcome. Although you can do everything right and a person still, may not be able to be resuscitated, but this will help to ensure that you're doing what you can. Remember, the call taker's questions are important to get the right kind of help to you as quickly as possible. Be prepared to follow any instructions the call taker gives you. Many 911 centers can tell you exactly what to do until help arrives, such as providing step-by-step instructions to aid someone who is choking or needs first aid or CPR. They advise to not hang up until the call taker instructs you to do so. So those are just some tips for staff. Agency culture. And when I speak of agency culture, I'm referring to just not being scared to call 911 if they believe the person is in an emergency situation. Staff can feel supported to call 911, and you as an oversight nurse, if they call you and it sounds like, you better call 911. If you got that in your mind, you need to be able to feel supported to be able to guide them to do that. The most important thing with this type of, just that culture of, you're not going to get in trouble. It's okay if you feel like it's a life-threatening situation or emergency. So just, make sure they feel empowered to call 911 if they feel like it's an emergency. Also, part of the culture could be to review what they would do in an emergency, as we talked about earlier, and what you as the oversight RN also review what your expectations are when there is an emergency. So if you have that prep ahead of time, you're least likely to, blank out and just not know where to act next. And it doesn't necessarily have to be like throwing the Annie, I used to call them Annie dolls, but the CPR dummy on the ground and practicing that way. Just simply just kind of running the scenario, even with your coworkers, talking about what would we do? What's our plan? Or even just thinking about it yourself. What would I do? What would I do in a situation like that? That will help. Let's see. And again, I want to reiterate, be sure and know your agency's policy. Can't stress enough that preparation is the key. And also staff having the needed items if they have to do CPR, such as a mouth barrier available in the home and or car, or any first aid materials that they may need they're in the home and well stocked. Also, emergencies occur so rarely. So it's hard to know how to act unless there's been a review of the policy and CPR and first aid trainings. You can even, review things just regularly, although they're not mandatory except for certain times, like annually or every other year. But you can still, refresh yourselves. Oh, another point I want to bring out is that when a person has individualized signals that they're having an emergency, then that should be something that staff is aware of who are taking care of that person. For example, the individual, and I thought of this the other day, and I've worked with this gentleman before, that you may be serving this individual and he has a seizure disorder. Well, the individual maybe does not have seizures very often, but when he does, they are very hard, and he often aspirates during his seizures and has trouble breathing and ends up needing to go to the hospital. So information like that is very helpful for staff to know, so they can make sure to get him medical help and call 911 right away if he experiences one of those hard seizures. That's just an example. There are, I'm sure you guys can all think of a bunch of different things. So what to look for with the care. Knowledge. Do you and the staff know what to do for the individual experiencing a medical emergency? Needed materials in place, if present, or an AED, which that's not usually in the homes, but depending on where you are, that may be available. That masks or any needed first aid supplies present and readily available to the staff responding. Another thing that you could think about too is what would they do if anything was missing? Or what if they had to use something and then just having that in place to where the product, like the mask or what have you, is replaced, just having a process for that. So that way, if they have to use it, that way it's replaced. And so if something happens again, God forbid, it'll be there for them. So after EMS arrives, are you or the staff able to give information such as medication being taken, medical issues, medical history, any recent changes or patterns noted? So having that like the chart handy, or even just as I said, having that we have that we can utilize our health passports, and that kind of has a blurb of medications and diagnoses and health concerns on it with the individual. And I think you can even personalize it and have a picture on it, but those are kind of handy so that way, whenever you do have to call emergency, EMS, then you can give that to them so they can have an idea of, okay, what's going on with this person's health, what could be going on with them, because sometimes it is just a mystery whenever someone starts having an emergency. So afterward, okay, debriefing is a thing that we like to promote. Department of mental health is very important. Does your agency have a way to debrief when there has been a medical emergency? When I'm done speaking, I'm going to drop in the chat. This is a link to our DMH disaster services. They have so many different things that you can look at that help with different kinds of traumatic events. Managing stress, which is very important, and especially during a pandemic, that has really added to all of our stressors, as you know. So I will drop these resources in the chat here in just a minute. I'm not able to copy and paste from that, but I do have them on a different paper. So yes, on the disaster services section, you can find resources under, there's several tabs, but there's an adults tab, and it has information for dealing with stressful intertraumatic situations. And I mean, I consider calling 911 or having to do CPR on someone. That can be very traumatic for someone, or even losing a loved one. Say they tried to get them help and then the person passes away. That can be very traumatic, or even just regular grieving for someone that they have lost, because that you get attached to people you take care of. So topics on the DMH website. For coping facts for adults, coping facts for grief and loss, coping with disasters and traumatic events, coping with traumatic event anniversaries, because that can be very difficult too, the anniversary of something just very traumatic, emotional first aid for adults, and then the road to resilience. So those are some things, and I'll drop that in the chat. Documentation. Don't forget that documentation is needed for any involvement in medical emergencies. Quality assurance with the documentation, whomever, maybe you as the Oversight RN will review some documentation. Everybody's agency or facility is different. The regional office RN will usually have a piece that they do related to quality assurance, whereas they evaluate the event and just kind of see how things go. They may reach out to you maybe they have a question, or just to check and see if if any resources or supports needed. And they also look at that to determine if there's any need for follow-up. Because we have it to where we're outside looking in, so we can kind of evaluate what we see in a situation from what's documented and say, oh, this could help, or things of that nature. So resources, the Just Not Right help sheet on our website can assist staff caring for individuals and help identify when to seek medical help or call 911. And yes, these links won't, I think I saw something pop up in chat. The links won't go away. These are all active links, and many of them are from our website. Regional office as a resource, a consultation with the regional office RN is always available for those receiving services. Physicians ahead of time, talking to the person's physician. That way you should be able to give directions on specific individualized questions regarding what is an emergency situation for this individual. Like, when should we seek further help when this individual displays such and such signs and symptoms? And then, of course, the American Heart Association and American Red Cross, or if your agency uses some other approved and accredited CPR certifying organization, that's always a good resource for reviewing steps with identifying an emergency and calling 911. So I'm going to stop sharing my screen and put those links in the chat. And I don't know, do we have any questions? Tricia, are you able to read or check and see if there's any questions while I do that?
Yeah. One question we have here is, does the mortality review apply to clients who have expired when admitted to the hospital or just at the home? So the answer is, if they're receiving waivered services, yes, the mortality review does apply to them, even if they were admitted to the hospital.
Thank you for answering that. Okay, here's one link for managing stress. And then here is the DMH Office of Disaster Services website that has a lot of, oh my gosh, it's good resources, you know. They take it seriously, and they're really trying to help with people's mental health and recognize that. And then this is going to be just not right. Here, let me put a little. Hopefully that document, you can share that document, and hopefully that will be of assistance so that staff can feel, more confident in what they're experiencing, because that is scary. You may go your whole life and not taking care of someone, not have one emergency, or things may be going status quo, and then suddenly someone loses consciousness, and you're just like, yeah, I mean, it's just not something everybody's prepared for, and staff working in the home, they are not necessarily have a lot of experience in that from past jobs or anything, and you get one training every couple years, so hopefully that will help. Were there any other questions in the chat? I don't see anything.
Seeing any, Leslie?
Okay, all right, well, thank you, Tricia. And let's see. All right, well, Tricia, may I introduce you for your part here? I'm going to turn the.
Certainly.
I'm going to give you the folder so you can present. All right, now I would like to tell you a little bit about my colleague. Pull this over here. Before I turn it over to her, Tricia Parker has been an IDD nurse for over 10 years. She earned her Bachelor of Science degree in registered nursing from the University of Central Missouri. She served as a regional office quality enhancement RN for the Central Missouri Regional Office prior to coming into the position she's in now to serve as the Community Health and Wellness Coordinator for community operations. Tricia is going to review StationMD service with you and show you resources for COVID-19 that are available out there that we have on our own website. So I am now pleased to turn it over to Tricia.
Thanks, Leslie, for that great introduction. I appreciate it. So I'm going to share my screen here, and you should be seeing it. Okay, so I'm just briefly going to go over StationMD, what it is. The division partnered with a telehealth service called StationMD back when COVID last year, the first wave of COVID, and it was just to make sure, you know, the doctor's offices and stuff weren't seeing people frequently due to COVID. So we partnered with StationMD. They are qualified and serve individuals with IDD. They are a 24-hour, 7-day-a-week service, and they act as a resource for individuals, families, and staff to call. Anybody who is receiving waivered services can utilize StationMD. Staff can download an app to their phones. I'm also going to take you to our DMH website here in a second and show you where it is on our DMH website. And anybody who's receiving, again, any Medicaid waiver recipients are eligible immediately to utilize StationMD for any medical concerns. And then we'll talk a little bit about monoclonal antibodies and their efforts with that here in just a few seconds. But what I want to do is take you to where it's at on our DMH website, and hopefully this will work. Okay. Maybe let me, wow. Up this way. I didn't know if that was going to work or not.
That's okay. You've got it.
Got that. Yeah, sorry about that, guys.
You're fine.
Let's see. This is our Department of Mental Health web page. You'll need to click on developmental disabilities. This is our COVID-19 banner. We'll discuss that here in a minute. But over here, you see this little blue button here for StationMD. When you click on that, it gives you the description of StationMD and their services. And then underneath, you have other information. There's just so much information, directions for downloading and using the app, frequently asked questions. And as you can see, COVID-19 vaccine town hall webinar series. If you click on that, they have some series that you can watch and some other live recorded events. And then it also has, if you're having guardians or family members, you know, wanting more information about StationMD, there's an individual and family packet, and there's letters. I'll just click on this one, see if it comes up. And this just kind of explains it again. So it's to make doctors available for our population who's at risk. Go back one. Oops. And then also here is information for your residential provider and agency guidance. And it has a history form that you can fill out. We also talked about, Leslie had mentioned the HRST Health Passport. And again, it has the individual and family packet here. So there's several ways you can get the same information, but always when you go to the DMH website and you see these little carrots here, click on those and you'll find a wealth of information. And so I'm gonna stop sharing that screen. We'll see if we can pull up my PowerPoint again. So I'm just going to kind of bounce around. I apologize. Okay. Oops. Get out of that for a second. That might work better if I just do it that way. Okay, so oops. Okay, so now we're going to do a poll question. And the poll question number 7 is, have you ever utilized StationMD for an individual receiving Medicaid waiver services? And we'll have a minute to answer this. And then like before with the other poll questions, it will tally it. And a minute seems like a long time when you're just watching the clock tick by. So again, while we're answering those questions, it is a 24-hour-a-day, 7-day-a-week service. It doesn't necessarily take a place of the primary care physician, but you know, in an instance where, you know, your staff or it's after hours, they can't get an individual in to see, you know, the physician, they're kind of concerned about something, as long as it's not a medical emergency, those are things they should be reacting on and encouraged to react on immediately. They can consult StationMD. StationMD can listen to heart tones and fields through their virtual service. So that's kind of cool. And it looks like we've ran out of time. So, okay. So we're about even there on yes and no answers on whether or not anybody's used StationMD. So we had 45 say that they've utilized it and 52 that have not utilized it. Okay. And then I think we'll do another poll question. For those that have utilized StationMD, how would you rate your experience with StationMD on a scale of 0 to 10, with 10 being the best possible experience?
And we changed the answers to that just a little bit to satisfied.
Oh, okay. That's
You're fine. You're fine. Satisfied, neutral, not satisfied, or never accessed.
Yeah, good.
Yeah.
And again, you have a minute to answer those, and then we'll tally those and share that with you. And I like telemedicine services. I've used telemedicine myself for simple things. Well, I had a toothache one time. I used not StationMD, but my teledoc service, and I was able to get antibiotics right away. It was actually less costly than going to my doctor or waiting to get into the dentist. And we got a few more seconds here left. All right, so the poll is closed and we'll wait for those tally results. Okay, so we've got 43 that were satisfied. We got a couple that were neutral, and then we have 43 that never accessed. Okay, well, thank you guys for taking the time to answer those poll questions. And I'll go to my next slide. So we talk about COVID-19. We'll talk more about COVID-19 and resources on the next few slides after we get done talking about StationMD. But one of the things that StationMD can be utilized is for consult regarding COVID-19 and specifically monoclonal antibody infusions. StationMD can assess the individual for readiness for monoclonal antibody infusion treatment and make appropriate referrals. I do want to make a note here that StationMD does not have infusion sites. But what they do is they're working around Missouri to access those sites, make those appropriate referrals, and they will also work with the individual's primary care provider to assure continuity of care and treatment options. So on the monoclonal antibody infusions in StationMD, we have provided the regional QERNs with a flyer for StationMD. And so if you have questions about StationMD and the monoclonal antibody infusions particularly, please reach out to one of your QERNs and they'll help you with that and help you with the information. And so I can't see the chat, Leslie. Is there any questions so far about StationMD and their service?
I am not seeing any questions,
Okay.
and I do see one person did say they are a huge fan of StationMD.
That's good. That's good. It's a good service for our individuals, and particularly, with the COVID-19, they're particularly at risk. If we're trying to keep them home and keep them out of the doctor's offices and out of the hospitals, StationMD is a great resource. We can use them, hey, we're not sure what we're seeing, but can we, they're complaining of pain, give them a call. Different, just don't utilize them for emergency services. That's not what they're there for. I just want to put that out there. When our staff should be empowered to call 911 when they think somebody is needing emergency medical treatment. And Leslie had mentioned that Just Not Right document. Here in a little bit, I'm going to take you to that when we talk about the Observe, Decide, and Act resources out on our DMH website.
Someone had posted that. Oh, I'm sorry.
No, go ahead.
Someone had posted that they feel like that if StationMD would be, that it would be utilized more if our facilities or homes had like a magnet with info on it. So it sounds like they just would like something more handy right there in the house to have for their staff.
Like a magnet on the refrigerator for calling.
Yes, I'm assuming that that's what they meant.
Okay. I'm not sure that that's available. We can definitely circle back with StationMD and see if we can't get something like that out. I'm not sure that they have anything like that. There is a downloadable app that they can utilize. And I believe there's a phone number, but they'll have to have the app for them to be able to do the telehealth service. So downloading the app's probably the best. But we can talk to them about, magnets and things, more resources like that. Any more questions? Oh, I just seen one pop up, but I didn't get to read it all, Kat.
It says, I downloaded the information page with the link to the app and info on how to access and laminated it for each of the ISLs that I cover.
Oh, great.
Another is how long will services continue to be available?
As far as I know, there are partners, so I don't know that there's an end date for that, for their service currently.
Okay. Are all homes to have the ability to video conference?
That's something that you would probably have to work out with your agency. I'm not sure how all the homes are set up, but they're typically utilized through, the downloadable app through your computer or your cell phone. So that might be something that you discuss with the agency on how to make that service readily available in the homes, if staff don't want to use their cell phones or whatever.
Another question is anyone having an issue with medication prescriptions being covered?
That I don't have that information and I can speak to that.
Is the monoclonal antibody therapy an overnight stay in the hospital?
typically it's not.
I think that's about it for now, as far as
Okay.
questions.
Yeah, and just to touch upon the monoclonal, sorry to interrupt, but to touch
No,
upon the
you're right.
monoclonal antibodies, how that would look is the person is perhaps evaluated by StationMD physician, perhaps their own like personal physician. They have to meet certain requirements, certain criteria, health criteria in order to have it. Namely, it has to be within a certain time frame from when they test positive or start showing symptoms. It has to be within a shorter time frame. They are then referred to an infusion clinic nearby. An appointment is made. They go in and they have the IV infusion. I believe they're monitored for possibly an hour afterward. I don't remember the exact time, but it's not very long. And then, as far as I know, they're able to go home after that. So that's kind of a brief rundown of it. I just wanted to throw that out there, and I'll be quiet now.
Yeah. No, that's fine. And here in a minute, I will show you a link that the DHSS link for the monoclonal antibody infusion sites when we talk more about COVID.
There's some things in the chat that I'll read out. Besides that, has anyone had any issues with medication prescriptions being covered? Another person said, we have not had any issues with medications being covered. We have had to let our pharmacy know that the prescription would be coming from an out-of-state doctor for them to fill it. Somebody said just multivitamins, fish oil, vitamin D, etc. And someone said, yes, sometimes I do have trouble getting medications covered by the insurance. I've had Walgreens say, Mo Medicaid say they won't cover meds because the prescriber isn't in Missouri when using WebMD. Another person said, we have experienced an outpatient release on antibody IV therapy just to confirm that it is an outpatient. That's just someone referring to that. Someone said they even used when one of our consumers, PCP, primary care physician, passed away while waiting for a new primary care physician appointment. That's good to know. I had one of my individuals early in the COVID adventure that received the monoclonal therapy, and she did come home same day. And another last one is I called a few infusion clinics in Colombia. They did not have it available yet.
Thank you.
I'm sorry.
Going.
Last one.
Okay.
I have had the StationMD not be able to write a medication because it was considered a controlled medication in the state where the physician was licensed.
Well, these are very interesting things to bring up. I really
They
appreciate
are.
it. This is so neat to know because, well, from what my understanding was, StationMD physicians are all licensed in Missouri. So I'm gonna take the comments just back to the table and just say, is this something that needs attention? You know, just to kind of make sure everything's going kosher. But from what I heard, through the always the chief medical, I don't know if you call him advisor, the chief medical person, Dr. Unicat from StationMD. I had asked him that because I wondered how is this going to work with the referrals to get monoclonal antibody infusions, and he said that they are all supposed to be Missouri licensed. So I will check and see about that controlled substance issue. Maybe there's something that needs to be ironed out with that.
Yeah, and thanks guys for making us aware of some of the issues that you're having, because we can definitely go back and have those conversations with StationMD and see if we can't puzzle those. Okay. So it looks like some are having issues with the controlled substances, and then there was one that's not. So we'll definitely go back and have those conversations with StationMD. Okay, so I'm going to move on to COVID-19 updates. A lot of what I'm going to do, guys, on these next couple slides is just take you to some of our resources. We all know that there has been an uptick in numbers. Missouri has been on the national news for our positivity numbers. A lot of those numbers that you're seeing is, due to the Delta variant across Missouri. It's in the sewer shed. The Department of Health and Senior Services website for Missouri and hotspot advisories. I'm going to take you to those. And this is where we get the information. If it'll let me get on here. Let's see. Oh, I might be able to open it from here this time. Let's see if that comes up. Nope. Might take a minute. All right. So this is the public health data from DHSS. When it comes up, my internet must be a little slower. And so this is Missouri at a glance. I'm not going to read all of this information. The link is on the slide if you're curious and want to go out there and see where we're at in Missouri. This webpage will also, you can look at by county, so you can enter your county. Maybe I'll put clicking on stuff and it might talks about our vaccination rates in Missouri, the sewer shed map, and testing. And so then you can select a jurisdiction. And I would love to do that, but it looks like it's going to take a while. But I am going to scroll down. And you can see we have data charts here from April to August. They do have the hover option to kind of let you hover over things. And then if you click on these jurisdictions, your counties, this will bring up your information. The hover option, Callaway County to date has had 6,396 cases per 100,000. And that's the PCR metrics. And then the antigen metrics. Oops, sorry, let me go up here. Like I said, just, pick your county. Antigen metrics for Carter County, 394 per 100,000. It also gives you a past 7 days. And it gives you a look at past 7 days compared to the prior 7 days. So this is an interesting website if you're curious of where you're at in your county. And then I'm going to close out of that and go back here. And then the other link that I wanted to show you was the hotspot advisory from DHSS. Let's see if it'll let me open it from here. Looks like it will. And it looks like there was one issued today. And you can see they started this back in July. And so and I'm just going to click on this one for September 15th for Bollinger and Madison counties and surrounding areas. These are areas of concern that they're watching really closely. And it talks about, it gives you the situational summary. It also talks about the hospitalizations and where we're at. Talks about the Delta variant. Talks about vaccination rates. Bollinger is at 26.4% and Madison is 29.8%, which is well below the national average and in Missouri. A lot of that can be due to population size, whether it's rural or urban, things of that nature. But if you're interested in the DHSS, they're the ones tracking the COVID stuff and the vaccination rates. Those are two great links. I use them almost daily when I'm looking at things. So I'm going to close that out. Do we have any questions about those two links so far? So then I do want to take you to another link, which is the Missouri Stronger Together banner. They do have a initiative out there where you can register to win. If you're vaccinated, our individuals are eligible to register to win as well. And here you can enter to win $10,000. And just some general information here about where you can get a vaccine, COVID test, recent news from DHSS and DESE, vaccination data, the supply data. And then if you go back up here, you can also click on these here. I'm going to try it. This is all from DHSS as well. And then you can look at statewide and county. And you can see this looks very familiar. And here's a graph of total doses administered over time. And that includes all of the Pfizer, Moderna, and the Johnson & Johnson. And then you can look at age group. You can see that our older individuals are up there on their numbers on vaccination. The age group, particularly of concern, would be the 12 to 17 and 18 to 24. We're still not quite there yet. Okay. So those are some resources. We have some additional resources that you can share with your individuals and their family members regarding COVID. I like this one because it's Missouri Plain Language Guide, and it was a partnership. Let me see if I can open that. The partnership, and you'll see it here in a second. I love this one. With the Missouri Developmental Disabilities Council and DHSS. And then you scroll down here. Where's it at? Oops. Oh, here we go. And I like this because it just puts things into, just plain language like it says. So it talks about how to find the vaccine. You can scroll through this. Talks about what COVID-19 is. As you can see, what you might experience with COVID-19, your signs and symptoms. How do you stay healthy? Very direct, to the point information. What do you do if you get sick? Call a doctor. Those things. Back to basics. Okay, and then it also has websites that you can look at. And we did look at the mostopscovid.com banner that we had. And that's a Missouri Plain Language Guide. And this you can share with your individuals and their families if they have questions about COVID and the vaccines. And then this one, we got several CDC resources. This one I'm going to try to go to. Go see if it opened for me. This one we have, this one you can print out in Spanish. And I like these because, and we shared these with our service coordinators. We have posters, the printable posters, social stories, interactive social stories, and videos. It kind of is geared towards the learner, and it's geared towards individuals with IDD. And so it talks about various subjects, the vaccination, of course, hand hygiene, testing. And of course, all of the, and we'll click on one of these, talks about masks. And I'm going to click on this just to show you what it looks like. And so this is a slideshow. Some of them do have videos. But it's a great resource to share as well. Okay. And I think that, oh, and where is the monoclonal antibody stuff? Oh, here we go. I think I skipped a slide. I'm sorry. Because I was like, no, I know I needed to talk more. So testing resources, let's go to that first. Testing resources, we get a lot of questions about, how do we access testing and the Binax Now. And I'm going to see if this will let me go to this. I'm hoping it will. Yep, I think so. So on our DMH website, this is where you'll find that information. It's the coronavirus COVID-19 information. It has information. This is provider-specific guidance, vaccine information. You click on any of these carrots. Talks about the vaccine lottery stuff. It also talks about flu. And then testing information. We get a lot of questions about this. Where do we access the Binax Now? Testing for our agencies. And this is where you would go for that. And then if you have any questions, there is a residential provider testing mailbox that you can send those questions to. And then I think there's, yeah, I think that's it on this one. Are there any questions about the testing resources? Also, bi-weekly, our division has COVID-19 update webinars, and they post those on this same coronavirus landing page, and those are recorded. And so if you're interested in hearing what's being said, all those recordings are posted here. And you can see there's quite a few of them. They also post Q&As. Okay. And then we'll talk about the monoclonal antibody infusion resource and site Locator. Open this hyperlink. Okay, so this is DHSS again, and this is their site Locator page. So if you're curious of where, oh, it's going to take me outside, so I'm going to go ahead and hit no. It also talks about eligibility. You can click on the map. Oh, I don't want to go outside of the web page. So if you click on that, it'll take you there, and then you can click on these little buttons here, or push pins, I guess is what you'd call them. And this is the most updated information that they have on those antibody infusion sites. Any questions? And we'll post the links and this slide with the posting of the WebEx today. Okay, and if we don't have any questions, I'm going to turn it back over to Leslie, and I believe she is going to talk about, I'm sorry, Leslie.
A whole variety of things.
Trying to get back to my, yeah.
No,
sorry, She's going to talk about.
I'm going to talk a little bit about assistive technology and some other things, and we will also talk about fall risk and prevention. So, and I did drop a couple of those links in the chat, but they will be available. We will make them available along with this recorded webinar. And if you go on our site, you will see all those resources, and you will be able to be taken over to the DHSS website to get more information. It's just real neat. Like if someone needs a lift to go get a vaccine, you locate the vaccine through the website, get a ride. It's it'd be a very valuable resource to people. And Tricia and I worked on getting information together so that we could share like a toolkit with the service coordinators. So that's been dispersed. So when they go in the homes and do their thing, or if they aren't going in the homes but they're touching base, they can always, hey, do you need any information about COVID-19 safety measures or vaccines or what have you? So anyway, thanks for all that good information, Tricia. Appreciate that. And I'm going to share my screen. Maybe. Okay, other important information. I had a just sort of a hodgepodge of different things I want to talk about, as well as technology first. Have you all ever heard of the Technology First initiative? And we will have a poll question for that. Empowering through assistive technology, the Division of Developmental Disabilities is committed to supporting all individuals with the opportunity to increase their independence through the use of technology. Empowering individuals to use technology is important for many reasons. Technology can improve quality of life, increase independence and privacy, provide tools that can, oh, am I even sharing my screen? I don't think I am.
No, we're not
I'm
seeing
sorry. Hang on just a second. Rats. I was on a roll there too. Okay. But you're all patient people and I appreciate it. Okay. I will pick up where I left off. Okay. So technology can improve quality of life, increase independence and privacy, provide tools that can increase safety and health, reduce costs, address the direct care staffing shortage, which we are all very aware of. Missouri is a technology first state. And if you think someone you support could benefit from assistive technology, please visit our webpage, which I will post in the chat. There are video links and other information on that page, so you can learn more about it that way. Real user friendly, and if you don't like to read a lot, the videos are good. So have you all ever heard of Technology First Initiative? And this is just a way to get that information out there. There might be different things that you guys can utilize technology first for, or that your individuals can. I'm thinking of something right now. It could be as much as things that they can utilize to help them with, with remember to take their medications. Different things that for hearing impairment, visual impairment. It's a really good resource. Just a few seconds left and we'll see what the poll results are. Too many picture things up here. Okay, so 22 people have, 65 no, and then 133 did not answer. Well, now you can say you've heard of it, and please definitely explore that site. I'm going to put that in the chat. How can I, let me see here. Click over here. Put that in the chat. So if you want to go and just check it out, it could make someone's life easier and, maybe help a person be more independent. Okay, I'm going to go ahead and go on and talk about the Relias platform. This is something, and Tricia was on a work group for this, but they were trying to find a way to help the oversight RNs working for the agencies. Okay, how can we help them with training for with delegations? And we do have on the Reliance platform, I'm going to change my slide. Okay, so I'm going to show you how, this is just what it looks like whenever you actually get to the point, but I'm going to go ahead, I'm going to stop. Hang on just a second. I'm going to show you how to get there actually, so you can actually look at it and see if that's something you would want to use for delegation. And I'm telling you, we would really appreciate your feedback, because if you guys like it, we'll get more. We'll see if we can get more out there. That is an option. So let me find my, hang on just a second here. Okay, thanks for bearing with me. All right, so we want to go to the DMH homepage. I have that as one of my favorites, so I'm just going to click right there. That's my little Missouri map. And then we want to go to the DD landing page and go down, and I'll put a direct link in here, but this is just, I don't know, I'm just walking you through it. There's more than one way to get somewhere, I guess. So now I'm going to go to community supports and education and learning. And here we have Reliance self-registration portal. So I'm going to click on that. And you don't want to go to employment support. You want to go down to the MoDD content self-registration portal and click on go to directly to the portal. And that does take you away, but that's okay. So my username, don't tell anyone. Let's see, and password. You guys can't peek. Okay, so here is where it brings me to. And what I'm going to show you is it will experience scheduled downtime. Oh, that's timed. Okay, so close. So we have this learning, current training. See, we have the Missouri Practice Guidance presentation, Nurse Practice Act, Fact or Fiction, which you guys you guys know about that. Or if you don't, you should. But anyway, Pro on the Go is what I want to show you. And see, it says Missouri Division of Developmental Disabilities Custom Library. So this is the start of our library, okay? And if you guys like it, we can expand upon it. But we have Trisha's work group decided that they really like this collecting specimens urine via straight cath. And it is an adjunct to, like, it could be an adjunct to the training you do with staff for delegating this task. If you, and it's up to you if you want to delegate. You do not have to delegate any task. But if you use your nursing delegation decision tree and you find that this is something that you want to delegate to staff, then you can, if you feel like that this supports what you're wanting to instruct, you can use this this right here to help teach about that, and and then go through the rest of your delegation, making sure that they know how to complete it, that they're well equipped for it. Then medication administration nebulizer. So there's something that can be used to teach someone how to use a nebulizer. I mean, it's not the only, of course, it's not the only thing you do when you delegate to someone. You got to make sure that they're competent, and then they can perform the task after you instruct them. But this is just something that if you guys wouldn't mind checking out, seeing if you can use it, and please give us feedback. That would be wonderful. And you're probably asking, well, how are we going to give you feedback on that? We have been talking about, we're going to do the survey after today, to see what you guys want to see in the future. But we'd also like to send out word in about 6 months and just kind of see if there's anything new that came up that you'd like to hear about next year. But also, I would like to touch upon that as well, and just see if anybody has been utilizing this resource, and just see if you guys want us to explore more options for things to help with your delegations. So does anybody have any questions about that? I'm gonna stop sharing my screen for a second because it's distracting. I'm looking all over the place here. See any questions?
There's one.
Okay.
Is there any way to merge user accounts on Relias if your agency created credentials for a user and the user also created their own account?
I think that's over my head. No. May I take your I don't know, but I will take your question and name and try to figure that out.
Phil Ware says not at this time. So I'm not sure who Phil is.
Oh, okay. Well, thank you, Phil. All right. And I'll let Heike know that that is a question that's out there. She's my guru for Relias. So I will just put that, I'm going to copy and paste it on a Word doc over here so that I can, because if you're, I don't know how all that works, honestly. Okay. Can you show us how one looks? Can you show us how one looks or works for Relias? Yeah. Yeah, I can do that. Okay. I'm going to share my screen again. I don't know, let's see. Screen 2. Okay, can you guys, all right, you should be able to see my screen now. So I'm going to begin this one. I always bypass the blocks if I can. I haven't gotten in trouble so far.
Collecting specimens, urine via straight cath. Pre-procedure. Before you start the procedure of collecting a urine specimen via straight cath, you first need to ensure this task is within your scope of practice.
Are you guys able to hear that at all?
Yes.
Okay, so we'll watch just a little bit of it. We don't necessarily have to watch the whole thing, but at least enough to get the gist of it. That was a good recommendation. So you
check the individual's
check
plan
it
of
out.
care, your organization's policies and procedures, and the physician's order. Check the person for a latex allergy. Use a non-latex catheter and gloves if needed. Gather your supplies, including specimen labels, lab requisition, plastic biohazard bag for the specimen, gloves, bath blanket, specimen container, straight catheter kit, and straight catheter. Verify the individual's identity using 2 identifiers. Explain the procedure and provide for privacy. Perform hand hygiene and apply gloves. Will you be performing this procedure on a female or male?
We'll say female. Kind of neat.
Place the individual in a supine position. Females should have their knees flexed with hips rotated out, or be in a sideline position with the top knee flexed. Use a bath blanket for privacy and dignity. Provide perineal care. Remove gloves and perform hand hygiene.
Okay, so that gives you a bit of a taste on what that looks like as far as utilizing that to help train staff. Does anybody have any questions about that? I thought I saw something come up in the chat. See, I'm gonna stop sharing my screen for a second so I'm not making y'all dizzy. Let's see, as an agency nurse, do we need special admin permissions in Relias to assign these trainings to staff? I cannot answer that. Does anybody else have any experience utilizing Relias? I have not used it from an agency standpoint. However, I can find that out. But I'm copying and pasting the question onto my Word doc. Okay. Oh, and then let's see. Someone in the chat says some agencies have their own Relias accounts. They cannot access this through their Relias, so they have to set up a new account. Okay. Okay. All right. Thank you for that information. I appreciate it. But yeah, I'll get that my mind wrapped around it too, so that way I can make sure to have that answer, because that, you know, it's available and we want you to be able to use it. Let's see, will there be a typed version to use as the delegation for the record? I don't believe so. Tricia might be able to answer that better than myself, but I believe that you would need to create your own. Is that correct, Tricia?
Yeah, the webinars or the on the pro on the go, sorry, are not really to take the place of the nurse doing the instruction. So you would still need to have that documentation. It's just a tool for the nurse to use.
Another question is, do support staff need to print a Relias training certificate for the records at the ISL?
Oh, I think that would be,
Ag-
oh, sorry, go ahead. Was someone saying something?
Okay, so again, it's just a tool that the nurse uses. So she would still have to complete the training and the training log and the delegation sheet.
Another is, so on the Relias Learning for the med classes, is there not any training on there? I was under the impression there is any, then told now by RSO that it's not a teaching / training, only testing. I see that there is teaching for other things. Since the COVID spike, I feel like there needs to be a teaching on there.
That's a very good question and a very good point. I will go to that. Hang on just a second, and I will share my screen in just a second. Okay, I'm gonna share. So the guidelines have not changed as far as the information that was released whenever, for the pandemic, since we're kind of in, we've been in a state of emergency and such, and it's not always safe to have everybody in a room. So if you are needing to do have I shared anything yet? Hang on. So if you are needing to do an update for level 1 med aid, hang on a second here. We still have in Relias medication administration for unlicensed paraprofessionals. They can take that for their update if you gotta abide by and make sure, just mind your P's and Q's and make sure that, you're utilizing it for, due to COVID-19 and for safety measures. Not just out of convenience, because there's just nothing like a classroom, honestly. At this time, we are working on a new med aid curriculum, and the med aid curriculum will be partly in Relias, and then the hands-on stuff will be with a certified instructor, and it is going to be updated, and hopefully it'll be out next year. But anyway, we'll keep you guys updated on the progress of that when we can. But I'm super excited. I've been getting to work on that project, and it's going to be really good. I've been a level 1 med aid instructor for a few years now, and I've even taught within the past few years. Even in a pinch, I taught, during the pandemic when all the nurses, there was an outbreak at a facility and nurses were tied up trying to do their thing. And so I taught in a gigantic room wearing a mask with people spaced out, just like 4 students. And yeah, it's a reminder that level 1 med aid curriculum does need updated, but we're working on that, and I'm seeing the light at the end of the tunnel. So anyway, I digress. Let's see, here we have interim DMH medication aid certification online exam due to COVID-19 pandemic. So yes, they can do a virtual class with a teacher instructing, just like pretend like you're all my students out there. I've taught this way too. All my little students out there, and we can interact and go through the lessons. Well, instead of doing a paper test, you can do this online test right here. And, or the students, excuse me. So that is an option, definitely, since, boy, it's just hopefully one way to make things safer and get the job done at least, because we don't want to sacrifice quality, but we want to make sure we can still do what we need to do, right? This could be a great resource of delegations. Oh, good. I utilize it for MedCert. Okay, good. And I've used it too. I've done the paper and I've done that one. And I mean, I think the test on there is fine. For Relias level 1 med aid, how do one complete? Oh, The update, they complete this, the Med Administration for Unlicensed Paraprofessionals for their 2-year update. And then if you're needing someone to watch them do their hands-on part, that can be a nurse that works for the agency. The new curriculum, we're still working out the details for that. That's on down the road, but we're going to have people, nurse instructors, take a course and then be able to do the hands-on stuff. But yeah, through the COVID-19, I'm not thinking of the right word, but kind of the exceptions or whatever, we're allowing that the agency nurse can watch them perform their practicum portion for med certification. Will it be on Relias only on DMH, or can it be set up on providers Relias access? I don't know. I'm just not a very techie person to know all that stuff, but I'll take your question. We'll definitely have Q&A, and this will be part of it. I apologize. I'm just not very good at that. JCLS Relias only and not paper test. Okay, they can use either paper or Relias. Okay. See, with the level 1 Med Aid changes, will an LPN be able to be the instructor? That is something we'll consider. There is a CSR that we need to look at and alter. And there's something else that dictates in another spot about it being an RN, but we're going to work through that. I'm going to get different people to work on a work group on that so that we can get things to make sense into how we want it and update things. Let's see. So on the practicum part of training, do we need to have the participant sign or virtual? Oh, that's all something that's covered on our website where Tricia showed you the COVID-19 page. It has a section for what to do with level 1 Med Aid during the pandemic, and nothing's changed otherwise as far as getting people certified with the level 1 Med Aid. We still utilize the DHSS curriculum and follow their rules. Let's see.
We have one that says, with the level 1 Med Aid changes, will an LPN be able to be the instructor?
Oh, that's where I was going with the CSR. We're going to be working on that. That's all I can say for the future. We're going to have work groups and work on the CSRs because there's some language in there that says for RN, for it to be an RN. However, it really doesn't necessarily have to be. So we're going to try to get all that updated because we want it modern, we want it up to date, we want it the best. Okay. And let's see, I'll just take a few more questions because we still have a little bit to go through. Let's see. Does testing online give the student an immediate certificate, or is there still a waiting period to receive proof of certificate? I haven't used it for a while, so I'm not really sure. So if you use the Relias, has anybody used the Relias platform recently for testing people with the level 1 Med Aid instead of the paper copy? Have they done that recently? And I apologize, I haven't taught for a little bit. It
seems to be immediate.
It's an immediate search to print. Oh, yay. Thank you. Thank you for answering that. Okay, thank you. Appreciate you guys speaking up or chatting up. Okay, but we still have, someone points out also, but we still have to process it at the regional office to get their level 1 Med Aid certificate. Yeah, and then don't forget the practicum piece because they do need to be, make sure they can do all the steps. Okay, all right, more on that, just kind of verifying what we said. Practicum is still in person, yes, true. Yes, that's true. All right. Great questions and feedback. I love the interaction. Thank you, guys. Now, let's see, for a full class, the practicum has to be completed, passing test. Oh yeah, definitely. Yeah, there's still the need for the practicum, yes. And in person. I don't know how we would simulate that. That's something I just don't know. There's just nothing like, you know, having someone there and just making sure you're doing that hands-on stuff right. It's just a very important task. Okay, so I'm going to go ahead and move on. And if you have other things, go ahead and drop it in the chat. As we said earlier, we're going to post the Q&A on the website along with our recording. And then if any of your colleagues or people you work with weren't able to catch any of this, hopefully you guys have found it useful, and hopefully they'll be able to watch it and gain some kind of take away something at least, that they've learned, in order to help out. Because I mean, it's a big job. We take care of people's lives. So any help or, feedback, we want to make sure we can do the best we can. And so I'm going to talk about, hang on. Okay, I'm going to show my slides. Okay, no, I'm not. I lied. All right, falls. Falls can be a very serious thing. Have you ever fallen as an adult? I mean, as a kid, yeah, okay. But do you remember if you were sore or how you felt afterward? Anecdotally, I was jogging in my driveway. The gravel was loose. I turned and fell, got right back up. But a day or two later, I couldn't get off the couch. And that was when I was about 10 years younger. So, it's painful. It can be damaging. It can be very painful, cause damage to a person that is not, and it may not even be readily apparent. Like I was fine right after, but it started hurting days later. And then we have people that we take care of that could be the same thing. Maybe they can't even express, like utilize words to express how they're feeling or what's going on. So then that, it's very puzzling sometimes to find out what's happening. Many of the people we serve also may have osteoporosis, which can lead to poor outcomes for those individuals if we are not identifying risk for falling or trying our best to decrease the occurrence. Like really, what we really need to embrace anymore is just prevention. Before something happens, before an accident happens, before a disease process happens, really prevention's the best way. And I know it's not always possible, but that is just something we need to keep in our minds. We are currently, we as in state QE or clinical operations team, are currently working on our fall tracking and follow-up and measuring thresholds in order to improve our quality of services and in order to better see what's going on, to alert regional offices so they can alert you all as to things that we're noticing. Because it's when you have a different perspective, like statewide or what have you, you get a different perspective, and you can and there's things. I mean, we're here to help support you all, so we're excited about working on that. So your regional office may reach out to you if there are trends or increases noted, which they may already be doing that. And that's okay. Okay, I don't know. Oh, good. That looks good on my big screen. This graphic, I hope you can see it okay. This data is collected through our event reporting process. Basically, it is showing the number of falls per quarter in orange, and in blue, it is the total number of different individuals who have fallen. So there are over 1,000 people who fell from quarter to quarter. I mean, it hasn't changed a lot. Many of the people, as you can see, the numbers between the orange and the blue, I mean, there's quite a bit. There's, okay, like this quarter here, 1,152 people fell, but there were 1,882 falls reported. So that means a lot of people fell more than once. And in some of the data we've looked at, man, there's a person that fell like 11 times in one quarter. Now that's a lot. Like there's something, going on there that needs to be looked at. Let's see. As you can see, that last quarter, which is fiscal year 2021, I'll use my little pointer, fiscal year 2021, quarter 4. So there's that's last quarter, and that's April through July of this year. and we had over 2,000 falls. Whereas see, it's been kind of 1,800, dipped down a little bit there, but then, okay, over 2,000 now. And so think about it this way, that's over 2,000 times that a person fell and may have a fall that could have detrimental effects from it, like hitting their head, which could lead to a brain bleed, broken bones, which are sometimes difficult to heal, depending on the person's other medical diagnoses, and then medications can make an impact on healing. And then sometimes people are not a candidate for surgery. So say they fall and break a hip, maybe they're not a candidate for surgery. And then what kind of outcomes do they have? I mean, they may die, they may be just incredibly permanently disabled from that fall. Sometimes they suffer with unmanageable pain as a result, especially if they cannot use words to communicate. That's just really difficult. Whenever that happens, their pain may be misinterpreted as an adverse behavior, so they're given psychiatric medications instead of getting to the root of the problem. Sometimes falls can be directly linked to the start of a chain of events that leads to death, unfortunately. So I want to bring this up also. We're in fiscal year 2022, Q1. We still have 1.5 months to go, and we are already at 1,552 falls with over 900 people who were involved. So I got 1.5 months to go, so we'll see how that goes. It's kind of, the trend's increasing, so we're gonna work together though, right? We're gonna work together and try to help people decrease fall risk. So why should we even focus on falls? Well, besides the obvious, we care. We don't want these people to suffer needlessly. We just don't want them to have all these problems. It's just will decrease their quality of life. But it is in the rule book. This is another thing, it's in our rule book. So CMS 1915C assurance. The state demonstrates it has designed and implemented an effective system for assuring waiver participant health and welfare. And then we have sub-assurances that go with that. The state demonstrates that an incident management system is in place that effectively resolves incidents and prevents further similar incidents to the extent possible. We do have our event reporting, and that's where we all come in, where we effectively resolve incidents and prevent further similar incidents as much as we can. We're not always going to be able to prevent stuff like this. I mean, we can't wrap people up in bubble wrap or make them not, hey, you can't sit, you can't move, you can't go anywhere. I mean, we still have to, everybody has to be able to live and do things and have their dignity of risk, but we got to try as best we can. So another sub-assurance, the state establishes overall healthcare standards and monitors those standards based on the responsibility of the service provider as stated in the approved waiver. So yeah, there's a lot of lingo that talks about health and welfare of the individuals. The person-centered planning process is very vital to ensure that the provider, here is 9 CSR 10-5.206. The provider shall ensure that patterns and trends of reportable events specific to a consumer are included and addressed in the consumer's personal treatment plan upon approval by the planning team. To the extent that the specific consumer issues are identified, the department staff may meet with the provider to discuss action steps to address and resolve issues, including submission of corrective action plans. So you know what corrective action plans are. We're here as a resource and to help support you, to help prevent these falls. We're in it together, guys. We are in it together. Okay, the fall event definition, this is what we utilize in order to determine what we report. The apparent, and this is so twisty saying, I don't mean it's twisted or whatever, but yeah, it's fun to read. The apparent witness, not witnessed or reported, unintentional sudden loss from a normative position for the engaged activity to the ground, floor, or object which has not been forcibly instigated by another person. So I'm walking along and I fall, but I catch myself maybe on my desk. If Joe pushes me, I fall. It's not really considered a fall. It could be considered something else, but not a fall. So we have a lot of those that happen, witnessed or unwitnessed. The state QE team looks at falls statewide. As I said earlier, we look for trends and things that stand out related to falls. Maybe we see one region who has had an increase in falls, and we're getting the ability to more easily drill down further to identify what individuals are having falls. And then we can work with our teams, we can work with regional office teams, we can all work together to help where the falls are identified. So that's just exciting. And I love technology in that way, that we're getting to where we can get reports and drill down quicker to say, oh, they need our help. It's cool. All right, poll question number 10. Are you notified when someone has a fall or falls? And you guys don't hesitate to answer. It's okay either way. If you feel like you want to work on your processes based on what you learned today or just in general, definitely communicate amongst your agency. I want to also mention it is important that you know your agency's policy in regard to fall prevention, and then what kind of follow-up they do when someone falls. That's a very important thing. I guess I could leave that up there since I'm sharing my screen. Got 39 seconds left. Okay. Let's see what comes up. Oh, we have 79 that say yes, they're notified, 11 no, and 122 no answer, and that's fine. All right, thanks. That's kind of fun, kind of interesting. All righty. Risk factors for falls. You probably know them by heart as nurses, but I'll review some just to kind of refresh your brain on these things. Potential health factors related to fall risks are seizures, muscle weakness, walking and balance problems, orthostatic hypotension. That is a big one and sometimes can go undetected. Poor vision, arthritis, stroke, incontinence, diabetes, Parkinson's disease or other neurological conditions, dementia, fear of falling, certain medications such as anticonvulsants, antidepressants, antipsychotics, benzodiazepines, opioids, sedatives, hypnotics, anticholinergics. The list goes on and on. You know that meds can and a lot of people are on several meds that interact with each other, so they're given more meds to cover up those side effects. Never-ending cycle. Anyway, a lot of that can lead to falls, as you know. Let's see, maybe they'll start falling when they are coming down with something like an acute illness, like they become weaker. Perhaps if they get a UTI or some kind of a lung infection, they start, to get weaker and start falling, or they get dizzy and fall. Environmental factors that would affect, or that would be a risk for falls would be dim or loose or faulty or broken. Oh shoot, okay, no, I got some on my screen. Okay. Let's see, loose wheelchair brakes, better chairs with the wheel, like, rolling chairs or even office chairs, beds that with wheels on them. If they're not locked, they can be a fall hazard. Clutter on the floor, as you know, liquid spilled on the floor, uneven flooring, furniture too low or too high from the floor. Oops. Okay, so preventing falls. Utilize assistive technology. Assistive technology such as motion sensing lights, options. There are options for inside and outdoor motion sensing lights, stairs, like LED lighting kits, personal emergency response systems that detect falls and alerts caregivers, or emergency response call centers or 911. That's available. That's got a monthly fee, but that it could be something that would help. Assess your environment for safety, and I have a link that I'm going to put in the chat. And it's just a generic checklist for environmental kind of checks. I was trained a long time ago as a nurse aide. Keep everything, make sure the floor is clear, make sure you wipe up spills, make sure this, that, and the other, to just make sure the environment's safe. Because, when you're taking care of geriatric patients, Well, that's one thing they teach you in the nursing home. And I've just carried that with me. I've been fortunate that I've had that carried with me. And so I feel like if we could ingrain that in people's minds to pay attention to the environment and gear them to say, look for fall hazards. I just think that would be just really great. Let's see, one thing. Okay, and I just said that. Okay, for monitoring or having safe environments. Help the individual to discuss with a primary care provider regarding any changes in their health and ability to ambulate. So if they are having issues, don't hesitate to reach out to their healthcare provider because there may be some supports that they need. Maybe they do have an acute illness or a short-term illness. Maybe their chronic illness is exacerbated and they're weaker and falling now. Maybe they won't need long-term supports to help keep them from falling, but maybe they just need some short-term assistance, some PT, perhaps a wheelchair even. I mean, just everybody's different, but it doesn't necessarily mean it has to be long-term, but just until they can get their strength back and be strong enough to be able to walk, without having to worry about falling. One thing that is help, but when a person has their ambulatory and they have seizures suddenly and they will fall due to a seizure and hit their head, oh my gosh, it's a tough situation because you want to keep them safe, but you don't want to force anybody to have to sit down all the time. So check with the primary care provider regarding the individual's recommended activity level, including exercises. Some exercises may assist with strengthening muscles and improving balance, but check with the healthcare provider definitely. Another link I would like to put in the chat is evidence-based fall prevention programs, which it's a website and it's got a list of them. What I'm giving you is the website list, but it's just got different things that you could possibly look into to see if that could help a person maintain or even get stronger so that they have a decreased risk for falls. Check with your primary care provider regarding possible prescribed therapies or adaptive equipment that may assist. If they assist them with keeping good eye health, and support the individual to see their optometrist or ophthalmologist and follow up on any change regarding their vision. Seems like I knew of someone way back that started falling, and that's what they figured out was going on. And I was so proud of them for figuring it out. It was so cool because then they didn't slap on another med, and you got the person taken care of, got supports that they needed. Okay, assist the individual to discuss with their primary care provider and pharmacist their prescribed medications and any potential adverse effects that could increase the risk of falls, which is difficult, but hopefully as time goes on, we'll help people feel more secure about being able to talk to their primary care provider about things of that nature. Sometimes it's difficult, but we're here to help support you. So repeated falls, that does occur if the person has had falls or even one fall with the potential for more. Has the person's team met to determine what strategies will prevent the falls? If they have met, then have they implemented the strategies that they decided on, like environmental checks or PT consult, for example? Like, this is just the scenario, but we have good intentions and our team meets and we're like, we're going to do this, this, and this, and this is awesome, and we're going to help this person. And then whenever we all go our separate ways, like the implementation piece doesn't happen like we anticipated it to, or something falls through the cracks. So that's one important thing. Make sure you're implementing all your awesome ideas to help this person. And if the person's in need of a consult related to someone who keeps falling, if you want to talk to another nurse, reach out to your regional office QERN for a consultation to see if there's anything else. Maybe pick their brain, pick other nurses' brains. That's just a blessing I have when I can work with other nurses and be able to bounce ideas off of them, because it really helps, because none of us know everything. And just by talking things through, it really helps to be able to come up with solutions. Let's see, but most of all, make sure the strategies that you come with, that you come up with to implement are in fact being implemented inconsistently. Make it a goal for that person and the people supporting them to know about the risk for falls. So everybody, hopefully, I know staff turnover is hard, but just try to, hey, this person can fall whenever they're walking outside on unsteady ground. Make sure, you're with them, or you're watching, or you're helping them. Let's see, make sure that your plans for implementation are okay with the individual and that they are in agreement and willing to take the actions you set forth. I knew a guy who really could have benefited from a walker. He uses one now, but not for years. He did not want to use it. He does finally now, but we had to think of all kinds of other ways to support him and help him not, keep him from falling. And he was an active guy. He walked around, but he had falls. I'm just going to kind of leave you with this here. If the person is still falling, go back to the drawing board. It's not done with just a team meeting. You got to really make sure that your plans are implemented, that people are following through. And I know it's hard. I know it's tough out there, but those are just some things that you can think about and take back and see if that can help you with your people. Resources that I have, I will put in the chat. Incidents and prevention of falls. We have Observe, Decide, Acts, which I don't know if we're reviewing that still on our call. And then this is the NCO evidence-based fall prevention programs, and then generic fall environmental risk assessment. I'm going to put all those in the chat for you. And I'm going to stop sharing my screen. And I worked up a sweat there yakking at y'all. Does anybody have questions or?
I can read some of them.
Sure, thanks.
If you have someone with extensive fall behaviors, however, cannot get PT, or I'm sorry, extensive fall history, however, cannot get PT and or not a good candidate, had neuro workup, however, not a good candidate for most testing due to sedation, specialists have been denied by insurance.
Oh, those tough cases. I'll just speak a little bit to it, and then Tricia, and then Michelle, if hey, you're still on our panel. If you guys have anything to add to that, they do. I don't know. This is something I should probably put in the chat as well. But Missouri Echo, it's like an outreach, and different people, like all of us, anyone can join them. You're all out. Well, I'm out in the audience too. But they have a panel of people who are like experts who have a vested interest, lots of knowledge, and you can post cases on there of people who you're just having a hard time trying to figure out maybe medications, trying to figure out their falls, just different things of that nature. And it's got expert people that put their minds together and try to help you figure out a plan. If you've exhausted other ideas, then that's one way that I've learned a lot from that. And they have a variety. They have autism, intellectual developmental disabilities. They even have a COVID one. But I'm going to find that website and put it in there if you guys are interested in that. Now, I don't know, Tricia, if you have anything to add to that from your experience of being a regional office QERN. With
the Echo?
No, with the if you have someone with extensive fall history, however, you cannot get PT and or not a good candidate. They had a neuro workup, however, not a good candidate for most testing due to sedation. Specialists have been denied by insurance. I guess basically what they're asking is, what would you?
Well, first off, I'm not the insurance person, so I can't speak to the insurance piece of it.
Mm-hmm.
Testing under sedation, we always have to, make sure we pull in the guardian and the primary care physician on that, because sometimes, the risk of sedation is not worth the test. You have to outweigh the risks and the benefits. And I think that's with most things. With some of our individuals, may require sedation for dental work or pap smear or mammogram or something like that. So I'm not sure on the PT/OT side what would be denied as far as insurance goes. I do know that several individuals on my caseload have had PT and OT for at least a temporary time, so I'm not sure about the insurance piece of that.
Another question is, can StationMD order a PT or OT or speech therapy?
That's a good question. They are there for consulting. And
I don't see why they couldn't. like,
I
we-
don't either. Yeah. I'm still listening to. I'm putting my stuff in here.
Another thing we have is we have to do EMTs on falls that are basically behavioral, i.e. easing themselves from bed or chair to the floor, then calling for help. These are then included in the fall statistics. We address them as behavioral, but they are included in the stats. We asked to have this included in the ISP as behavioral and not a fall, but it was denied.
I apologize, but I was typing when you were reading that. Can you repeat the last part of that, please?
It's basically someone that they serve, quote unquote, falls, but they basically, it's a behavioral behavior, and they ease themselves from the bed or a chair to the floor, then call for help.
Mhm.
And then it's included in their fall statistics.
Mhm.
They tried to address them as behavioral, but they are included in the stats. And they asked if they could have this included in the ISP as behavioral and not a fall, but it was denied. Denied by who?
I can't supersede anything that anybody's saying, and there's not anything I'm gonna say on here that I'm not gonna contradict what decision, whoever made that decision. If you're not witnessing the fall, who's to say what happened? And if you get behavioral services involved with that, try to figure out, what is the purpose of the behavior and how to keep that person safe that way. Because I mean, if we do see someone that has a lot of falls, and when we get to investigating and looking into it, usually that'll come to light. Major thing that we, really want to focus on is people, keep people from becoming seriously injured, having to live with long-term disability or pain when it comes to falls and falling repeatedly. So yeah, that behavioral, I'll tell you, when I first started my career with IDD, I worked with a lot of people who had challenging behaviors, and there were a lot of things that they did to hurt themselves or appear hurt. For whatever reason, and it was a real challenge. I think things are looking better though as time progresses, because we do have more behavioral resources, and that's always something that you could look into for people who are have challenging behaviors. And your regional offices are a resource to help you. Service coordinators too. I don't want to leave them out. See, I had an issue with an individual as well. We did add it to their IP as behavioral, documented in notes, but not EMT as it was noted in IP. It just depends on the person's situation and the team, how to handle that. There's just not a blanket statement for everyone, as you guys have figured out. No black and white, because everybody's different. We can't treat everybody do the exact same things with everybody. See, the process of getting home modifications and OTPT funded, then the equipment approved plays a huge role in the increase in falls. Wow. Huh. I can imagine just hearing from friends and different people about who have to deal with challenges of, well, someone, close to me, dealing with Medicare and getting different things paid for the person's support needs. And does sound like it can be a very big challenge.
There's a belated question. I don't think that we answered it. But we have someone that's asking, at what point do RNs do remote visits for their patients during these COVID times?
There is not any guidance put out there yet, so it is up to the agency and their discretion of how they go forth with monitoring their people and checking in with them.
So
Oh, sorry, Trisha, were you getting ready to speak?
yeah, I was just going to speak to that a bit.
Yeah, please
So
do.
the expectation is that we're doing those face-to-face visits. What you have to look at is what is the situation You might have somebody in the home that's COVID positive. The individual might be COVID positive. Can we do those face-to-face visits, outside? But if you're choosing not to do a face-to-face visit and you do it remotely, it needs to be documented. And the reason why you chose to do that remotely versus face-to-face needs to be documented. And I hope that helped.
Oh, poodle. I put the Missouri Telehealth Network, the Echo link, if you guys want to check it out. And I put it, hang on a second. I jammed it up into the actual words. I didn't put a space, so you can just click on it or copy and paste it easily. There we go. See, RNs don't
Can I
follow the
speak
same
to the fall situation a while ago?
Ah, sure.
I just want to say I have a client who has that problem where falls are just a perpetual issue and it is behavioral. Putting it in the ISP is very helpful. That way it helps, staff coming in know that this happens, this is a potential for problems. Maybe there is a way of addressing it in the ISP that kind of helps them understand which one should be reported and which one shouldn't be. And sometimes you exhaust all options and there really is no other option other than just being creative and making sure that you document. As long as you have documented everything that you've possibly done, you possibly could do, everything that the staff has done, make sure that all that documentation is there, because sometimes there's just nothing more you can do. Unfortunately, you've exhausted all options. Insurances are very difficult to deal with. Medicaid is a pain sometimes to deal with when it comes to these things. This particular client has done PT and OT several times. They do a really great job while they're working with them, but then insurance or Medicaid says we have to stop paying because you've met however many visits you're allowed. And so then that stops and then the client starts to decline again. So, document. There's nothing more really to do. Get creative, and short of wrapping them in bubble wrap, just observe it and document. That's all you can really do, unfortunately. I wish that there was a better way that we could say to the insurance company, come and stand and take care of this person and see what's going on. And there just sometimes isn't that option available. So kudos to you for trying to come up with inventive ways. And I hope that you can find some way, but just make sure your staff are document. And again, you're having to leave it up to the documentation of staff, but that's where your assertiveness and your knowing your role in that reporting is a big deal, because that way who's having these frequent falls and maybe you can come up with something that somebody else hasn't thought of yet.
Thank you. I see something here. RNs don't follow the same policy as the SC and QE nurses as far as remote visits at this time. And it's a question. And no, Tricia just outlined how that process is supposed to take place. So yeah, they're still expected to go to the homes unless for other reasons, if their homes broke out with COVID or what have you, whatever. It's you weigh pros and cons. It's up to the agency, and you need to document if the nurse is not going to the homes. Okay. Pull something else up here. I believe we have covered everything we have needed to. Oh my gosh, we have a minute to spare. That's awesome. I am so thankful for all of you joining us today. And I just really hope that you can take something away, and I hope something that we did today was useful for you. And please don't hesitate to answer that survey question. I believe Kat had explained that once you close out, the survey question will pop up, and it'll say, what can we do for you in the future, for next year's. So let me look at my notes here, make sure I'm not missing anything. No, that's just it. But thank you so much for joining. And you just have an excellent rest of your day and keep fighting the good fight and taking good care of those people. You know, we're all in it together. So appreciate you guys, and you all have a wonderful afternoon. And I want to thank Kat and Tricia and Michelle as well for being on the panel.